starting to get involved with this, obviously you're very involved in doing CCSVI procedures. What's been most frustrating for you along the way?
I think the most frustrating thing is not being able to look at one individual patient and tell them what they can expect with this procedure. So I can certainly talk about what we've seen with various groups of patients, but when I talk to an individual, for example, a gentleman I treated today, and he said, what is this procedure going to do for me, and how is this going to help me? It becomes very hard to answer that because we really haven't seen any very concrete patterns of response, meaning I can't say that every 30-year-old woman responds this way or every 60-year-old man responds that way. So I think for now it's been frustrating from our physician's perspectives to be unable to answer that question to an individual patient.
Sure. And what's been the most surprising or promising? Or
I mean, clearly that's an easy one to answer. Just some of the patients whose lives we've impacted. I mean, it's surprising, promising, and exciting all at the same time. You know, when we take a patient who walks in with a cane and walks out without one, then that's amazing. When you take a patient who, wanted to take their 3-year-old child to Disneyland and didn't feel they were able to until they had this procedure, then they email me back a few weeks later and say they're down in Florida having the time of their life. You know, that's something that is just unbelievable from my perspective.
Yeah. And what do you say to the people who say, well, that's fine, but it really is just MS waxing and waning, or it's really the placebo effect?
My answer may surprise you. I don't have an answer. I don't know the answer to that question just yet. I mean, I'd love to be able to say it's not a placebo effect, but I don't know that. And I think when people use the term placebo, they use it in an incredibly negative way. And I don't think that's necessarily the case. I think that if any option can motivate someone to marshal resources that they have inside them and to help them advance their own individual health, and I think that's a great thing. So I don't know if it's placebo, or I don't know if it's a true effect of the procedure. I do think certainly that when someone calls us and says, hey, they felt great for a day or two, then their symptoms came back, that in that particular case I'm concerned about a placebo effect. But when I speak to my patients who are 8-9 months out and they're still telling me how good that they feel, I just find it hard to believe that that's placebo.
Okay. Can you help give us a little bit of context of how what you're seeing in the veins of MS patients compares to what you previously have been seeing in a different overall population regarding their veins and their health that way?
Well, keep in mind that it was previously very unusual for any interventionist to be working in the internal jugular veins or the azygos vein. Now, we do approach the internal jugular veins regularly to put catheters in place in people who maybe need treatments for cancer or treatments for dialysis, but to truly catheterize the jugular vein for the purposes of performing a venogram, that's unusual. So it's hard to know for sure if we took 100 people off the street or 100 people with a different medical condition exactly what the inside of their internal jugular veins would look like. But when we look at the population of MS patients that we've studied, I think that we've been struck by the wide variety of appearances that these veins have. So in many patients, certainly the sizes are discrepant, either between patients or even between size in an individual patient. But that's not that much of a surprise because we know that in many cases there are dominant veins on one side or another. What's surprising is the degree of narrowing that can be seen in a single vein. And that means that when you compare the mid portion of the vein, maybe on the side of the neck, and look at it compared to the bottom portion of the vein, sometimes when we would expect the vein to get bigger as it moves towards the heart, we see that it gets markedly smaller. And not only that, but we see that the flow just gets held up, meaning it's not emptied efficiently from that vein. And finally, we sometimes or often see collateral vessels, which essentially means that there are other vessels that have opened up or become a little bit more dominant in terms of them helping drain the blood from that vein. So in other words, when the blood is trying to make its way down a jugular vein and encounters an area of narrowing, the blood still has to leave that vein. And so it finds other veins to work around the blockage or the area that isn't functioning normally in order to drain it. And we can see those collateral veins on a regular basis. So we know that something just isn't right. But again, the key piece of this is that we don't know exactly what the veins of quote-unquote the normal healthy population would look like if we studied them as well.
Okay. And even more specifically, does the venous wall itself seem to be different in patients with MS?
Yes. Clearly, there's some irregularity in some veins. We see that more often in the azygous vein than we do in the internal jugular vein. Mm-hmm. We do see some thickening of valve leaflets as well at the bottom of the internal jugular veins. Mm-hmm. So these are some of the findings that we're clearly seeing in some patients. And we just don't think that's normal. We think that the flow characteristics in those veins should be better. Mm-hmm. And we're seeing flow abnormalities together with actual physical abnormalities that are causing narrowing of the veins. And we think that together, that's pathology for that individual patient. And by fixing that, we think we're helping the patient.
Yeah. And those abnormalities, are those kinds of, in particular, have you seen those in other kinds of venous diseases or any other?
Well, typically the common venous diseases that we tend to be involved with are the venous obstructions seen in dialysis patients, mm-hmm. and the venous obstructions that are seen in patients who mm-hmm. suffer from blood clots in their legs. Mm-hmm. And, certainly in a patient who's experienced some blood clotting, we do see some irregularity of the veins. Mm-hmm. But in the dialysis population, that's not what we see. So I think to some degree, these are unique findings in what's turning out to be a very unique population of patients.
Okay. All right. Well, let's talk about, since you all have treated at this point, 500-ish or so patients. What can you tell us that you're seeing? Where are you most commonly finding the narrowing? And
well, we've seen findings across the board, but in general, there are what we call anatomic areas of narrowing and pathologic areas of narrowing. So, frequently we see three areas of concern in the internal jugular vein. The first is at the very top of the internal jugular vein, mm-hmm. as the vein runs very close to the cervical spine. Mm-hmm. We know that part of the cervical spine can oftentimes compress the vein. And, that's clearly concerning because the vein itself becomes narrowed and the flow becomes limited through that area of the vein. But at times, we see perfectly good flow through a narrowed area of the vein in that particular region, and we don't necessarily consider that a problem, because that's just the patient's normal anatomy. Mm-hmm. And unfortunately, doing an angioplasty in that area may or may not help the patient, since the problem is that the vein is being compressed from the outside. Mm-hmm. And that's why in those particular areas, stents may be necessary, and I'm sure we'll talk about that a little bit later. Yep. The second area we see some narrowing is right in the mid portion of the internal jugular vein, right by the jawline. Mm-hmm. And the reason for that narrowing is that the common carotid artery lives right there next to the vein. And in some patients, it's the artery that could be compressing the vein. And again, just because we see narrowing in that area doesn't necessarily mean it's a problem. It just means that the artery is compressing the vein, and doing an angioplasty may or may not help in that situation. Mm-hmm. I think the third area, which is clearly the most common area that we see what we think is abnormal narrowing in the vein, is at the base of the internal jugular vein. And by the base, I mean right by the collarbone, mm-hmm. right where the internal jugular vein joins with the subclavian vein that's coming from the arm. And right there in many patients, there's a valve. And we think that the presence of that valve, in addition to some other really previously undescribed pathology, could be leading to narrowing of the vein that inhibits flow out of that area, out of that part of the vein. Mm-hmm. So the most common area of narrowing is the base of the internal jugular vein. The other two areas I described are definitely some combination of normal and abnormal, which I really believe we've yet to define, mm-hmm. but can at least be explained by the patient's normal anatomy.
Okay. And are you seeing any dare I say, correlation between the location and either the severity of the MS or the symptoms that the patient experiences?
No, I have not seen that at this point right now. I don't necessarily believe that we've seen exactly the same things that Dr. Zamboni described. Mm-hmm. For example, we're not just seeing azygous vein disease in patients with primary progressive disease. Mm-hmm. We're seeing that in a number of different patients. And so I think that we've yet to be able to very neatly classify patients into some of the patterns that have been previously described.
Okay. And since you mentioned azygous, tell us about the other veins that you've been checking out in addition to the internal jugulars.
I believe a lot of this lies with what's going on in the azygos vein. We've seen some particularly impressive abnormalities in the azygos vein. For most people who've at least looked into this on the internet, they know that the azygos vein looks like a big candy cane. And what we're typically seeing is some abnormality at the top part, at the curve of the vein, and that's the azygos arch. Now, there are valves in the azygos arch in some people, and it's very clear that in some patients we see very rapid outflow, meaning that everything is fine. The blood just works its way up the azygos vein and goes right back towards the heart. And in other people, we see the flow really being held up across the azygos arch. And we believe that either a combination of a valvular abnormality or an intraluminal web or membrane of sorts inside the vein may be responsible for causing an outflow problem that really can be addressed very well with angioplasty. Okay. And so, in general, the findings that we're seeing are across the azygos arch or right at the top of that descending portion of the azygos vein. That's more often than not, that's where we see abnormalities in the azygos.
Okay. And so are you checking everyone, all the internal jugulars and the azygos?
We are. We're routinely looking at both the right and left internal jugular veins as well as the azygos vein. Okay. And I know where you're going with this because I know that a lot of people are talking about looking at other veins. And, certainly as we learn more about this field, we try and pay attention to what we're hearing about what other people are doing, and we try and look and make some conclusions for ourselves. And one of the first areas that we did that was in the area of May-Turner syndrome. Now, as you and others may know, May-Turner is a syndrome where the artery that's bringing blood to the right leg is actually compressing the vein that's bringing blood from the left leg. And so there's a problem with blood flow from the left leg. And before all this talk about CCSVI came to our attention, we really focused on May-Turner syndrome in patients who had blood clots in their left leg. And it was potentially an underlying cause of decreased blood flow from the left leg and maybe something that was responsible for the patient forming a clot. And in those patients, if we had the opportunity to intervene on them, we might think about putting a stent in that area in order to remove the compression of the artery from the vein and to allow blood to more efficiently exit the left leg. The thinking in CCSVI is that some of the veins from the lower part of the spine may actually empty into the common iliac vein and then make its way back to the heart through the inferior vena cava. And in order to do so, that blood has to travel right through the area that's typically affected by May-Turner syndrome. And that really forms the basis for the recommendation that patients be studied from the left femoral vein instead of the right femoral vein. Because this way, that could be studied, and we can see if that too is a problem in this population of patients. So we set out to do that. And actually, one of the pieces of research that we're presenting at this year's Society of Interventional Radiology meeting is our experience looking at May-Turner syndrome. And we studied 160 patients that we looked at from the left side. And what we found was, I believe it was a 17% incidence of what we would call May-Turner syndrome. The interesting thing about that is twofold. First of all, none of the patients had left lower extremity symptoms. So the classic idea of May-Turner syndrome potentially being responsible for leg swelling or other typical venous manifestations of that problem were completely absent in those patients. And the second thing is that if you look at previous studies regarding May-Turner syndrome, we know that the incidence of asymptomatic May-Turner syndrome in the normal healthy population is around 17%. The range is somewhere around 6 to 25%. And so with those two pieces of data in mind, we really don't believe that the incidence of May-Turner syndrome is significant in the MS population, and we stopped looking routinely at that vein. And we stopped looking because in order to see it, we have to give more X-ray dye, which can affect a patient's kidneys. We never know how much dye is too much dye. And so we don't want to waste the dye looking for something that we don't think is significant. And the other thing is, in order to see it, we have to apply radiation over the pelvis. And again, we don't know how much radiation is too much radiation. And, in this era where we're focusing so much on radiation safety, we are of the belief that looking at things that don't need to be looked at is the best thing we can do for our patients.
Sure. And you'll be presenting that meeting is in March?
In March in Chicago, that's right.
Okay. And any other veins? I mean, people often mention the lumbar, the vertebral veins. Are you...
Well, we do oftentimes look at the vertebral veins. A lot of times we look at them from the top down because when we look at the upper part of the internal jugular vein, it's not uncommon for us to reflux contrast into the vertebral veins. And if we see them well, we actually do look at them all the way down into the chest. So we oftentimes get a look at the vertebral veins. And the other vein that we look at sometimes is the left renal vein. And the reason why we look at the left renal vein is because sometimes the veins of the azygous and hemiazygous system can actually drain into the left renal vein. And if there's a problem or an obstruction to flow right where the renal vein joins the inferior vena cava, then that too can interfere with venous outflow from the spine, and people call that nutcracker syndrome. And so, we've been looking at that, and really I think we're finding similar things to what we found with May-Turner syndrome, but we are checking that out for a while just to see if there's any validity to that line of thought as well.
Okay. And, you were careful as you were speaking to emphasize flow and how flow may or may not exist with a narrowing. And I'm wondering if you could just tell us a little bit more about that, for people how to think about narrowing or even stenosis compared to flow, and what matters and how you're going to make decisions based on that.
Well, sure. I mean, keep it. It's a good question, but keep in mind that we don't necessarily really know the answer to that question. This is a new entity, and we're learning all the time. So I think that ultimately, if you have 100 blood cells on one end of a vein, and those cells want to get to the other end of the vein, and they can do that without any problem, then that's normal flow. Now, if you start narrowing the vein, but it takes the same amount of time for those 100 cells to go from one end to the other, then that narrowing isn't necessarily significant because blood flow is fine. At some point, that narrowing is going to interfere with the ability of those blood cells to get from point A to point B. And typically what ends up happening is the body wants to get those cells from one end to the other, so the blood flow starts to speed up through the narrowing. So this way, it takes less time. The blood flows faster, but the narrowing has impacted flow. And at that point, treating the narrowing will help restore normal flow. So to me, my answer to that question is it's not the narrowing that's important, it's the impact on flow that's important. And right now, it's a very subjective view of the veins. We inject dye inside those veins, and we look to see how fast the dye clears from the vein, because there's ongoing flow even though we inject the dye. And so it is somewhat subjective, and we make that determination that even though maybe there's a narrowing in that patient's vein, the flow is okay, and therefore treating that patient with angioplasty may or may not make a difference for that patient. And that's what we try and look at very carefully. It's very clear when a narrowing is interfering with flow, because the dye that we inject sticks around longer than it should. And so we inject dye and it just sits there in the vein, and that's reflux. That's what people quantify as reflux or classify as reflux. So we look at all those things and not just narrowing in order to make a decision to perform an angioplasty or not.
Okay. And so let's talk about angioplasty and stents, because it sounds like there's sometimes that the stents are the way to go and sometimes angioplasty is doing just fine. Can you help us sort through that from your perspective?
An angioplasty is a procedure where a catheter, which is a long tube, has a balloon built onto it. These balloons are sausage-shaped, and they can be sized. So, we have on our shelf balloons that range from 6 millimeters in diameter, or even smaller, all the way up to 20 millimeters in diameter and even larger. So we can pick a balloon that is appropriate for that patient's size veins. And I know that there's a lot of talk right now on the internet about what exactly is an appropriately sized balloon, and I think that right now is just one of those unanswered questions. You're going to have people who are in the big balloon camp and think that the biggest balloon possible is what's appropriate to use in a vein, and you're going to have people in a smaller balloon size, which really means that the balloon is slightly oversized. So if we look at all of our history with angioplasty and in all the different parts of the body, we typically work under the construct that choosing a balloon size that's 10 to 20% larger than the normal size vein is an appropriate size balloon to use. And that's the premise that we work under right now in our practice. So we do oversize our balloons, but we don't go too high. There are some places, most notably in Kuwait, I know that's spreading out to other areas around the United States, that using much larger size balloons to get a more definitive kind of disruption of the valve may in fact be the way to go. But at this point right now, there simply is no published research to back that up. And so, when studies are performed and that technique proves to be something that's effective in this population of patients, then I think anybody would want to pay attention to that. But right now, our feeling in this practice is that we're going to stick with the general philosophy of angioplasty that's been around for a couple of decades in terms of mildly oversizing our balloons by 10 to 20%. And by mildly oversizing those balloons, we're getting a stretching effect on the veins and, in fact, are creating a controlled injury that we hope will enable the vein to heal in a wider state and allow for more improved blood flow.
Okay. And how do the stents fit in with?
Well, right now I can give you our philosophy of stent placement, and that may differ, in other centers. But
sure.
Right now we view stents as a solution to a problem that may be caused by angioplasty. So in other words, when we go in and we treat a vein with angioplasty, we hope that the vein is either going to look better, the same, or worse after that procedure. And our goal is obviously for it to look better. But in some instances, it can look worse, that the injury we create with an angioplasty may in fact serve to cause more narrowing in that vein by injuring the vein. And at that point, the flow that maybe was impacted, for example, 60%, may now be impacted 90%, and that vein may be at significant risk for clotting and shutting down completely. At that moment in time, and really only at that moment in time, it really makes sense to place a stent because the stent can go in and really restore a more normal size diameter to that vein and allow for blood to flow a lot easier.
Okay.
The problem, however, Randy, is that stents can clot. And so once you put a foreign body inside the vein, there's certainly a chance that clot can form inside that stent and serve to disrupt flow itself. So I think one key to placing a stent is making sure that the patients are put on blood thinners after in order to be certain that the blood keeps flowing through the stent. And the other key to placing a stent is appropriately sizing that stent because we do know that there's been a case of a stent migrating from the internal jugular vein into the heart. And while that patient did okay, the fact is we really would rather not have that happen.
Sure.
And so whenever we're in the position of having to place a stent, we really do believe in significantly oversizing the stent so that the force that's causing that stent to push against the wall of the vein actually keeps the stent in place.
Have you... with patients with the oversized stents, though, have they developed temporary nerve damage from that?
We haven't seen that. We've definitely seen people who've been a little bit uncomfortable. The veins are soft before we start, and now with a stent in place, they're somewhat more rigid. So patients definitely know that the stents are in place. But what we found in pretty much all the patients that we've treated with stents is that goes away with time, that the patients get used to it. I'd say right now the biggest problem that we're having with stents is keeping the stents free of clot. And we clearly have seen some patients who, even despite the adequate use of a blood thinner, have clot form in their stents.
I'm wondering what recommendations you have for aftercare and how they might have changed since you've been doing procedures.
Well, I think we're trying to answer two questions with our aftercare recommendations. The first is the vein open? Is the vein that we treated open? And really the best way to tell that is with an ultrasound. And I think there's very little doubt that ultrasound can really do a good job at looking at the internal jugular veins and telling us if there's flow inside those veins. Unfortunately, there's no great imaging test to see if the azygos vein is open. So short of having the patient undergo another venogram, or a hit or miss MR venogram, which sometimes can show you the azygos vein and sometimes can't, it becomes very difficult to know based on an imaging test if the azygos vein is open, which is why the second thing that we look for becomes, I personally think, more important. We want to know how the patients are doing. It's important to say that we're not treating pictures, we're treating patients. And so we always have to wrestle with, well, the ultrasound showed one thing, but the patient is telling us another. So if the patient tells us that their clinical symptoms have improved and that they're really seeing significant clinical benefit, whether it's 3 months or 6 months down the road, then to be candid with you, it really becomes less important what the ultrasound shows. And this is our opinion, because we're doing this procedure to make patients feel better. Patients feel better, then going back in and treating an ultrasound abnormality really may not be doing much for the patient. We just don't know that. And so we're trying to balance that. I realize that may be a somewhat controversial statement to make, but we really don't know what the right thing to do is, and we feel right now that being cautious and making sure that the patients are feeling better and making that our number one priority is the most prudent way that we can go right now.
And what things in terms of the aftercare for the patient do you recommend that patients do to take care of themselves after the procedure?
Well, we really are concerned about the clotting that we've seen inside these vessels. So we believe strongly that if a patient has had an angioplasty procedure, that they need to be on some type of medication to make clotting less likely.
Okay.
And right now we're recommending aspirin. We recommend a full-strength aspirin after the procedure. Over the course of 3 to 6 months based on the patient's individual medical condition. And then we're starting to recommend converting that to a baby aspirin for the long term. If a patient has had a stent placed, then right now we believe that Coumadin is the way to go for these patients. It's an aggressive blood thinner, but the fact that we've seen that these patients had a stent placed, remember, they had the stent placed in the first place because there was a problem with their vein during the angioplasty. So we think because of that, these patients may be at risk for their stent clotting, and we have seen that. We've seen a significant percentage of our patients have clotting within the stents, and so we think that Coumadin is the recommendation. So we, in other words, we have our patients on either aspirin or Coumadin, and we are recommending right now that patients get an ultrasound at least 3 months after the procedure, then every 6 months to monitor the patency of the veins. But again, the third part of that is continuing to have good communication with the physician or any physician that's been treating you, so we know exactly how you're feeling and what changes the procedure has led to for you.
People have mentioned lower blood volume because of inactivity or even lack of adequate hydration as potential problems after treatment. Are you seeing that?
No, we really haven't seen that, but I think, certainly recommending good hydration is good on a number of levels, so I don't have a problem with recommending that for patients, but we really haven't seen that correlate or have assessed that right now with what we're seeing in these patients.
Okay. So let's talk about what you have seen in terms of the effectiveness and the assessment of what you've seen. You famously said that you feel there's a third and a third and a third of outcomes you're seeing, and could you describe that?
Sure, and I actually think that that's been holding. So I think in general what we're seeing is a third of the patients who really respond terrifically. Everyone would say that the procedure's made a tremendous impact in their lives, and whether that's in the area of cognitive clarity or improvements in fatigue and overall energy level. Some people report changes in all of a sudden developing warmth in their hands and their feet. Some people do report improved balance. Reduction in the MS hug sensation that a lot of people experience. These are the types of things that we're seeing in that 1/3 group. The other third that we talk a lot about is the third that just doesn't respond, that simply goes to this experience and really doesn't see any significant change, maybe outside of a change in the first day or two, but short of that, they really don't see much. And the other third is that third that's right in the middle, that maybe sees an improvement in 1 or 2 of their symptoms, but their dominant symptoms still have stayed the same. In other words, they can see something, but it's not what they hoped for, and they're not that happy about it.
Yeah. And any insights into who falls into what camp and why?
No, I'm a terrible predictor of who's going to do well after this procedure. So I have been unable to really look at one individual, as I mentioned earlier, and be able to predict which of those groups they're going to fall into. And what becomes frustrating is that it isn't even always the severity of their venous disease. So you might intuitively think that if someone has very severe venous disease and we treat them and they look great when we're done, that person would respond well, and that has not always been the case. At times it's someone with very mild disease who we look at and wonder if it's really impacting them, and we go ahead and treat it, and they do terrifically. So I just think our definitions as to what is a problem may have to change when it comes to these patients in this condition.
How so? How would you change those definitions?
Well, I mean, classically, I think in the realm of vascular disease, we often talk about a 50% stenosis being a quote-unquote significant stenosis that needs to be treated. But, we have seen patients who've had more mild disease, and we've treated them because we've seen that degree of narrowing still have a significant impact on flow, meaning that we see reflux and we see problems with just the blood emptying from these veins. And by treating them, we've made a clinical difference in those patients, that they have a sustained improvement in their symptoms. And so if we just looked at the percent narrowing in their vein, we might say, oh, that's mild, they don't need to be treated, when in fact, treating has helped those patients.
I see. Okay. And how about retreating? Have you you've treated enough patients now. Do people come back around?
We have. We've definitely seen patients who call, and right now, admittedly, we've taken a somewhat conservative approach to that. And my patients who may be listening to this will probably nod their head, because I'm sure they've heard me tell them that we want to see how you responded to the initial procedure. And at times, it becomes difficult to justify going back into the veins of a patient who never felt better after the first procedure. And you just ask yourself, if we're not going to do something completely different for these patients, then why should we be bringing them back in the first place? And so, at least for now, until we get some more information about this procedure, we've really been looking at retreating patients who describe their response as being really excellent. So in other words, if a patient calls me and says that they had several weeks or several months of an unbelievable response to this procedure, meaning that the vast majority of their symptoms have been improved, their quality of life significantly improved, and they were just extremely happy, and then one day they woke up and everything kind of was back to the way it was, then I'm far more likely to bring that patient back and look at them than I am the patient who really never experienced a benefit in the first place. Because I'm just hesitant to bring people back to do the exact same thing.
And what are you finding with those patients who have experienced that change and they do come back?
Well, I'm in some cases their disease has definitely worsened. There's the false sense out there that an angioplasty doesn't really cause any problems in the vein, and that all the clotting problems or major problems with the veins have been in association with the placement of stents. I will tell you that we've seen several patients who have called us and described the clinical scenario that I laid out, and we bring them back and look at them, and a vein is blocked, completely blocked. And in some cases, we're able to get through that blockage and place stents in those patients. And in other patients, we're not able to do that, and we have to leave them with a blocked vein. Now, they've compensated for that. So in all of those patients, we often see very significant collateral blood vessels, which are effectively draining blood from the central nervous system. But in the world of CCSVI, any flow that's non-anatomic may be leading to prolonged duration of time for flow to leave the brain, and that may be responsible for at least a component of that patient's symptoms that may be caused by CCSVI.
Okay.
So in other words, we're finding that some patients have venous disease that has worsened since their original procedure. We've also seen some people whose veins look exactly the same as they were when we've left them. And in those patients, we've sometimes gone in and done a touch-up angioplasty. And I think to some degree there is a law of diminishing returns, that we're not necessarily seeing those patients get back to the way they were immediately after their first procedure. And we don't, at least I don't necessarily have answers as to why that may be the case. But we do have patients out there that felt great after their first procedure, and after the second procedure really haven't noticed that significant of a change. And I think that needs to be further studied before we aggressively retreat hundreds and hundreds of patients.
Got it. And you were saying at one point that there's just a lot of many steps in all of this, and that in some sense we started at the beginning and have jumped to the end, and there's many steps in between that need to be explored. So can you tell us about what you want to explore, and then tie that into your clinical trial?
Well, I think that whether it's the MS Society or the Society of Interventional Radiology or many professional groups around the world, the only certain thing you can say about CCSVI is that we still have a lot left to learn about it. That it's a very exciting idea put forth by Dr. Zamboni, and I think that many of us, obviously including myself and the physicians I work with, have jumped over a lot of the intervening questions in order to offer this treatment to people. We're doing that because we've seen that the treatment can make a difference in people, but that doesn't mean we know all the answers or can answer all the questions surrounding CCSVI. So we don't necessarily know why this happens, or what the exact nature of the vein problem is, or in which patients that tends to occur in, or tying together the types of MS or even other neurologic diseases that may be affected by CCSVI and subsequently can be treated and see improvement. So we know that there's a lot of questions to ask, and we know that there's a lot of steps in between the putting forth the idea that Dr. Zamboni did and treating patients like we and other places are doing. So we're certainly setting out to try and answer some of those questions. the Society of Interventional Radiology put together a research consensus panel, and it was a group of kind of the thought leaders in this area, and we really concluded that a lot of the initial work by Dr. Zamboni and others needs to be validated and repeated in order to be certain that the foundation of knowledge is consistent across the world. And so certainly, our center and other centers are busy at work trying to look at some of the basic questions surrounding CCSVI. The MS Society has been supporting a lot of more basic science studies to understand CCSVI, to determine exactly what's going on inside those veins. But I think, in essence, the question that people really want to know is, does treating this help patients? And there are lots of different levels of medical evidence, but I think many people agree that ultimately a trial that randomizes people who receive treatment and people who don't receive treatment, and then trying to get them to objectively report their symptoms and have doctors objectively evaluate them to see what changes have occurred, is what it's going to take to understand the role that treatment may play in these patients.
And tell us about your particular clinical trial.
And that's what we're doing. What we set out to do with our neurology department here at Albany Medical Center is to arrange a study where patients with MS are evaluated to see if they have this venous disease, and we evaluate them with a Zamboni protocol ultrasound. And if there's evidence of a flow abnormality in the internal jugular veins, they're seen by our neurologist, who looks at the status of their MS and the neurologic symptoms and problems. And ultimately, we put those two together to determine if a patient is a candidate for the study. And if they are, then we bring them in and perform a venogram. And if the venogram demonstrates that there is disease that should be treated in the veins, we then stop and open an envelope which says treat or don't treat. And at that point, we do what the envelope says. And we keep that from the patient, who obviously has agreed to participate in that study. And we follow that patient for a period of time. Us and the neurologist will follow the patient. And ultimately, we'll know if there's a difference between the patients who were treated and the patients who were not treated. Now, obviously, we're hopeful that we see a difference, but I think the objective nature of this study will really help to answer some of those questions. And if it shows that the procedure doesn't help everybody, then at the very least we hope that it will show who it can help and maybe even answer why it will help them.
And those who were not treated initially, who fell in that arm of the study, they subsequently can get treated, will get treated? Yes.
At the conclusion of the study, they will certainly be the first people that we will offer treatment to.
Okay. And how long do you anticipate the study lasting?
Well, ideally, we want to follow patients for 18 months to 2 years. We'll see. We're going to see how the results go. Obviously, if the results are as good as everybody thinks they're going to be, then there's certainly a chance that we can stop the study early. And we have controls in place in our medical center that will evaluate the patient's results as the study's going on and will help make that determination.
Okay. And how are the neurologists feeling about the study that you're collaborating with?
Well, I mean, I think that they're appropriately skeptical. I think that, there's a lot of questions that need to be answered. And frankly, I think it's great that the neurology department here at Albany Medical Center is open-minded enough to want to participate in a study to help answer these questions. So, I'm very very proud of the department, and I think that it's terrific that the medical center is pulled together to help answer a question that could potentially help a lot of people.
Sure. And this study is still open to patients who are within driving distance?
Yes, it's just that the follow-up requirements, I think, really make it unrealistic for someone to hop on a plane every couple of months for an examination. So ideally, what constitutes ideal driving distance, I guess, is ultimately up to the patient.
Okay.
But, I think that's really what we're looking for, to be fair to the people who want to participate in this study.
Okay. Would you mind telling us again the example that you gave of a patient who contacted you who was not pleased with the design of the study?
Oh, sure. I know we talked about that the other night. We did have one patient from the Midwest who called and was really actually very angry about the design of the study, asking me if she had breast cancer, would I want to put her in the same study, which would give her a 50-50 chance of not being treated. And I think it's important for patients to know that CCSVI, the concept of CCSVI and the treatment of venous angioplasty to treat this problem has really not been proven to the satisfaction of just about anybody in the medical community. And so, again, we're offering this procedure, as are many other centers in the country, because we've seen with our own eyes patients who benefited significantly from it. But from a medical evidence standpoint, it just hasn't caught up yet. And so we don't know for sure if we're doing something that's helping this patient population. So we feel ethically okay to not offer a patient the procedure because we really don't know for sure if we're helping a particular patient or not.
Okay. To remain.
So it's not the same thing as withholding a cancer treatment from somebody because we know, based on years and years of study, that withholding cancer treatments from cancer patients will kill them. And we can't say that about this type of CCSVI study.
Okay. 2 remaining questions for you. What would you say to a physician who's considering getting involved in dealing with MS patients and CCSVI?
Well, I think it's an exciting area to get involved with. I think that it's new. So I think for any physician jumping into this, you have to be aware that it's definitely new. You can learn, certainly we can pull the information that we know from other areas of the body, but it is a unique set of veins that respond uniquely to angioplasty. And it's a unique set of patients that most interventionalists have not yet had experience dealing with. And so I think it's something that can bring a lot of excitement to a practice. And but don't be caught up in thinking that this is the cure-all for this disease, because I think that at the very least we know that this procedure doesn't help everybody. So I think jumping in, understanding that patients know a lot about this, and personally, we all enjoy working with patients who are very knowledgeable about their medical condition and about this treatment option. And so I think any physician needs to be prepared for that, needs to understand exactly what the patients are seeing and what information the patients have so that they're prepared for the questions that the patients are going to be asking. And again, just understanding what the limitations are of this treatment right now.
And finally, what words would you have for patients who are contemplating this?
Well, I think 2 things. I think the first is that this is new, and some patients are going to be comfortable with that, and other patients are not going to be comfortable with that. So, I think that any patient needs to understand that the physician that they see may not have answers to all their questions because this is a new entity and a treatment that really has been incompletely studied to date. So some patients will be okay with that, and some patients are going to sit home and say, let those guys try this out. Doctors learn more about it, then I'll jump in and see if it helps me. And so you have to decide what type of person you are, and if you're comfortable trying something new, which we're very confident has low risk and high potential for gain, then I think that this is certainly an option to try. I think that when I hear patients that have had this done 4 times in 3 months or even more, then I start to get concerned because I think that this may be something that's definitely worth trying once for many people. But I'm concerned about flipping that risk-benefit ratio when multiple treatments are done. So I would encourage patients to be open-minded, to hope for everything and expect nothing, and to be realistic in what this procedure may be able to offer them.
Okay. And any advice in terms of what they should look for in terms of a physician?
I think someone who's willing to admit the gaps in our knowledge about this. I think that anybody who says they know everything about CCSVI is probably not telling you the truth, because that the level of knowledge just hasn't gotten there yet to enable any physician to be able to say that. And so I think that's the key thing. Yes, we can share our experience with you, and yes, we can share what we know, but I think there's going to be many times that a physician should say, I don't know, to your questions. And if you don't get any I don't knows, you may want to think about who you're dealing with.